I think a lot of the data about how we treat second line was actually derived from data of patients who had received VEGF inhibition in the frontline setting. And so, not to say that it's a little bit outdated, but we need data for the second line reflective of patients getting dual IO therapy frontline, which is the current standard. The best data that we have, um, you know, of patients who have received prior IO and then got a subsequent therapy comes from the Cantata study. If we look at the control arm on that trial, that was a trial that looked at the combination of cabozantinib plus teliglenistat versus cabozantinib alone. But on that study, over 50% of patients had received prior IO, and you can get a sense of what is the efficacy of cabo in a IO treated population. And cabo was approved initially based off the results of the Meteor trial, of patients who had received prior VEGF inhibition. There was like 4% of patients on that trial who had gotten prior IO. Other data come from the combination of lenvatinib everolimus. Again, that study mainly looked at patients who had received VEGF inhibition as a frontline, but we do have good data for that as a second line regimen. Tivozanib is also another option that can be considered based off of the TiVo-3 trial. And on the tivozanib study, which was really designed as a third and fourth line study, there was a large portion of patients who had received prior IO. And so you have demonstrated efficacy of tivozanib in the post-IO setting. There's a handful of studies that are looking at dual IO VEGF therapies in the refractory setting. Contact 2 is looking at atezolizumab plus cabozantinib. That has completed accrual and hopefully will read out soon. The TiNivo-2 is looking at the combination of tivozanib plus nivolumab, and that trial is currently accruing. So I think what we do in the second line setting is really going to evolve as these additional studies kind of read out. The other thing that I will say is belzutifan is an FDA-approved agent now for VHL syndrome, a hereditary form of kidney cancer. It is being tested in a large phase 3 trial compared to everolimus that's completed accrual, and we're also eagerly awaiting the results. That's a HIF2 alpha inhibitor, and certainly holds promise from the early data that were presented from the phase 1.